Hi, and welcome to the Cancer Grace webinar series on bladder cancer. My name is Ramy Sedhom, and I'm here with Dr. Elizabeth Plimack from Fox Chase Cancer Center. Dr. Plimack, thanks for your time. I would love to give you the opportunity to introduce yourself, where you work, and what you do.
Sure. Thanks so much for having me. I'm Dr. Elizabeth Plimack. I work here at Fox Chase Cancer Center in Philadelphia, where I run the GU Medical Oncology Group and GU Clinical Research. My research focus is in bladder cancer and kidney cancer, and I also treat and am expert in the treatment of patients with bladder and testicular cancer. So it's really exciting to be here to talk about bladder cancer with you.
Great, and thank you for being with us. As you know, a big part of what we'll be speaking about today is the role of immunotherapy in bladder cancer. The first topic that we wanted to discuss is the role of immunotherapy in the neoadjuvant treatment for bladder cancer. But before embarking on the topic, would you like to explain what neoadjuvant treatment is?
Sure, absolutely. So many patients with bladder cancer, in fact, most of them have their cancer limited to just the surface of the bladder. And for those patients, the urologist can instill various therapies, including BCG, to really treat and control the cancer. Once the cancer has invaded into the muscle wall of the bladder, it's a different story. Those kind of cancers like to grow and spread. And we know that in order to cure a patient with muscle invasive bladder cancer, we have to remove or otherwise definitively treat the bladder. Part of that treatment involves neoadjuvant, currently chemotherapy. This is because while we think all the cancers in the bladder and imaging may show that there's no spread outside, our imaging can't pick up microscopic pieces of cancer that may have already escaped the bladder. Our systemic therapies, chemotherapy or immunotherapy, circulate throughout the body to attack and kill the cancer cells wherever they may be. And so we know from clinical trials that by giving this chemotherapy, or in the future perhaps immunotherapy, before surgery, we increase an individual patient's chance of cure. And since we're going for cure, we tend to really lean heavily on this modality in order to increase those chances. So neoadjuvant chemotherapy is chemotherapy that's given in advance of surgery with the intent to then remove the bladder afterwards.
Fantastic. Thank you for that explanation. I heard that you were hinting at some of it, but could you describe to our audience what some of the potential benefits of neoadjuvant treatment may be compared to treatment after surgery?
Sure. So in large clinical trials, we know we help increase the rate of cure when we give chemotherapy before surgery. We haven't really definitively proven that by giving chemotherapy after surgery, we can achieve the same results. And there are lots of reasons to suspect why this might be. The chemotherapy is the same whether you give it before or after, but it's possible that giving it before, there's less tumor out there for the chemotherapy to need to clean up before surgery. The other thing is patients are usually healthier and in better shape to undergo chemotherapy before surgery. It's a lot harder to do that while recovering from a major surgery. And the converse does not seem to be true. Patients who get chemotherapy before surgery tend to still be very good surgical candidates and able to successfully go through and recover from surgery after their chemotherapy. So this is why in the guidelines, the recommendation is to give the chemotherapy before surgery for patients with muscle invasive bladder cancer, again, to increase the chance of cure.
Fantastic. And the other growing area of interest in the field, as you mentioned, is potentially about the role for immunotherapy before surgery in the neoadjuvant setting. Could you extrapolate or talk a little bit more about that?
Sure, absolutely. So fortunately for patients with bladder cancer, immunotherapy has come to be a really useful tool for some patients. In the metastatic setting, these are patients whose cancer has already spread, and we can see that spread on imaging. For those patients, we know that there's a group of them who do really well with immunotherapy, meaning their cancers shrink and sometimes stay shrunk or invisible for a long time. So it makes sense that we would think about taking this very successful modality forward and using it in place of chemotherapy in the neoadjuvant setting. And fortunately, we have two clinical trials that looked at that, the Abacus trial and the Pure-01 trial. These trials looked at two drugs, atezolizumab and pembrolizumab, and these drugs were given to patients, just like I described, with muscle-invasive bladder cancer, no evidence of spread on the scan. And what was really impressive is that when the bladders then were removed from the patients, a proportion of them had no cancer in them, almost the same proportion that we would expect to see with various chemotherapies. And so, given the differences in the treatments, there are reasons to think immunotherapy may be preferred going forward, but we will need large trials to prove this, and those trials are ongoing.
That sounds very exciting, especially the piece about finding sometimes no signs of cancer during the surgery. I know from reading a lot of the literature in the field, it seems to be a big quality of life issue. Who has or does not have their bladder, especially in that setting.
Mm-hmm.
Moving forward, you did hint a little bit about fitness. As we both know, bladder cancer is a disease of older adults with a median incidence age about early 70s. Sometimes there's medical comorbidities as to why one may not be a candidate for surgery, and at other times disease characteristics that make someone not the appropriate surgical candidate. What we wanted to ask you, what are the settings in which you find yourself prescribing immunotherapy for such patients?
So that's a great question, and I think you hint at something really important for every bladder cancer patient we see in conjunction with urology and medical oncology, both here at Fox Chase and at other academic institutions. And that is, we have a set of tools available to us for patients with muscle-invasive disease. We would love to cure all of them, but we don't want to create more damage than we sort of need to in the process. And finding that balance and fine-tuning it for each patient is our challenge, and where we lean on studies and our own expertise. So what you're asking is a patient who may be at risk for having more complications from either chemotherapy or surgery, which is sort of the general recommendation for most patients, chemotherapy followed by surgery. What other options do they have? And there are a few, and some do involve immunotherapy. So one is for the older patient who really just doesn't want aggressive treatment at all, we don't try to cure them. We try to keep their quality of life up for as long as we can. And in that case, usually we can observe them and watch them with scans. And when the cancer does spread, we can then consider them for immunotherapy at that time. That's sort of the most conservative approach or palliative approach. For other patients, we sometimes use radiation to the bladder instead of surgery. And with radiation to the bladder, we give a gentler form of chemotherapy concurrent with radiation, again, with the goal of curing the patient. And so that is a reasonable option as well. And then also here at Fox Chase and Johns Hopkins and some other centers, we're looking to see if chemotherapy given before surgery can render such a good result that for some patients, they don't need surgery. It's very experimental, and it's based on biomarker work that we've done, but that's a path that we're actively exploring. In terms of using immunotherapy before surgery on its own, and then sending every patient to surgery, that approach is one that is being actively investigated in randomized controlled trials. There are clinical trials with pembrolizumab and other drugs that are launching now, and we're really looking to test the hypothesis of whether giving the immunotherapy before surgery will be as beneficial, if not hopefully more beneficial, than the chemotherapy we could currently give. So far, all those trials do involve surgery, however. So again, you can see lots of options. It really depends on the patients and the situation and the goals and values of each patient.
Fantastic. Thank you for explaining all of that. Now, kind of shifting over to the metastatic setting, one of the roles of deciding between whether someone is chemotherapy fit or not fit for chemotherapy, and when you're deciding along those paradigms, where do you find yourself thinking about prescribing immunotherapy?
So that's a great question. So for the patient that comes to our clinic newly diagnosed with metastatic disease, that's disease that's spread to other areas besides the bladder, the first piece of the conversation we have is kind of the hardest, which is that this isn't something that we can say, standing here today, we can cure. And so our goals become maintaining the best possible quality of life for as long as possible. And so once those goals are established, we can discuss the various tools we have to achieve that relative to the risk benefit for each patient. So on the list of things we can offer patients coming to us in the frontline setting are chemotherapy with cisplatin, a gentler chemotherapy without cisplatin, or immunotherapy, either alone or as part of a clinical trial in various combinations. So here, I think we really lean on patient preference, the ability of the patient to receive cisplatin or not, which depends on kidney function and other things, and also really biomarker tissue testing. So we know that if we test the bladder tissue and look for PD-L1 staining, that's a certain test we do in the lab, takes about 3 weeks to get back, we can determine if that patient is likely to benefit from immunotherapy or not likely to benefit from immunotherapy. And so I generally test all my patients in the frontline setting for this. For some patients, we don't use that information. We send it off and get it later because we just start them on chemotherapy. That seems to make the most sense. But in my clinic, for every patient for whom I'm considering immunotherapy, I wait for that PD-L1 result because I know it really will make a difference in terms of how they do with immunotherapy going forward.
Fantastic. And the last question we want to ask, immunotherapy is a relatively novel therapy compared to chemo. And oftentimes, there's some misconceptions or misunderstandings about the role of immunotherapy or the response rates of immunotherapy. From your personal experience in clinic, what are some of the common misconceptions that you find yourself talking about with your patients?
So I think the press has done a great job of kind of painting the broader full picture of immunotherapy. And I would say several years ago, we were in the position where there was more hype than substance. And now I think we've really balanced out what patients can expect from immunotherapy. What I tell my patients is when it works, it can work really well. And that's a reason to go for it and try it. But for about 10 to 15% of patients, again, leaning on the single immunotherapy drug data, they're going to have a bad autoimmune event, meaning the body's immune system, either in addition to or instead of attacking the cancer, goes against a healthy organ system in their body. And those symptoms can be severe. They can be life-threatening. They require prompt attention and treatment with steroids. And it's a tough thing to go through. It's another complication in their cancer treatment that we wish we knew how to predict and avoid, but we don't yet. And so when thinking about immune therapy, the side effect profile really has to be fleshed out in detail. For many people, they don't have any side effects, but for those that do, they can be severe. I think the other thing to remember is that in terms of shrinking tumors, chemo does a better job usually than single agent immunotherapy. If you take 100 patients, more of them are going to have their tumor shrink in response to chemo than they would in response to an immunotherapy. And so if you're really looking to just shrink up a lesion that's threatening or get rid of a symptom, chemotherapy sometimes is the best way to go at first. And the other thing is that we're not talking about either or immunotherapy or chemotherapy. It's more sequence, right? Most of our patients will see both modalities across the spectrum of their care. And so we're really trying to decide which to try first.
Fantastic. Dr. Plimack, this was all very helpful. We appreciate your time, and most importantly, we appreciate all the work you're doing for bladder cancer patients.
Thank you. Thank you for having me, and thank you to all our patients who have enrolled in trials and advocated for change in funding for this disease.
Absolutely. Thank you very much, and we hope to have you on with us again.